Muirwood, who I've had the pleasure of working with more closely recently, but has certainly been a friend and colleague for a number of years. So very excited to have her back in Oklahoma. Anne is currently editor-in-chief of the Journal of Human Lactation. She's an associate professor of pediatrics at Boston University School of Medicine and director of their breastfeeding center at Boston Medical Center. She gained her undergraduate and PhD degrees at Cambridge in England, her master's in public health at the Boston University School of Public Health. She was first certified as an IBCLC in 1999, so I beat you by 2 years. The year she helped her hospital become the first baby-friendly hospital in Massachusetts and the 20th in the USA at that time. She began her career as a journalist, but she's been working in breastfeeding since '97. Her particular specialty is the Baby-Friendly Hospital Initiative. She's published 40 papers in the medical peer-reviewed literature, 17 of those related to baby-friendly. And she a whole theme. Did I do that? I upset you. Okay. And she edited a whole themed issue of JHL on the Baby-Friendly Hospital in August of last year or so. And you have a flyer in your folders that right now for March, there's free access to all of the online content of JHL, so you can certainly go back to that August edition as well and see there's a number of baby-friendly articles. Anne has served on multiple projects as a consultant. Her clients have included the New York City Department of Health, the Navajo Nation, and from 2010 to 2012, the state of New Jersey on a CDC-funded project shaping New Jersey, the New Jersey Baby-Friendly Hospital Initiative. And most recently, she was hired as a consultant by NICHQ on the Best Fed Beginnings, and where she serves as a national faculty in a 3-year CDC-funded initiative. And of course, she's helping us here in Oklahoma, too. When not working, Anne raises ducks, chickens, 3 sons, adopts pit bulls, and travels widely with her Greek husband, Mike. So, very fun person.
Thank you, and thank you all for coming. It's great to have more than half the hospitals in the state at the very first meeting, so well done, guys. And actually added to my credentials or my stuff is that most recently I got a job consulting for the Indian Health Service, so I'm working on that as well. So this is going to be talking about the 10 steps, but not in some kind of like really pedantic way. I'm trying to make it a little fun. So the goal is, though, to look at the 10 steps and hopefully get you guys oriented to the 10 steps and to some of the things that go along with them and some of the myths and things around the 10 steps that we can help you to clear up. And I have Trish sitting right here, so if I get anything wrong, she can jump it. We also talk about different implementation strategies, get rid of some of those myths, and identify how these things are tested. So as Becky mentioned, I am the editor of the Journal of Human Lactation, and last year was my first year in that job, and one of the very first things I did was to have a themed issue on baby-friendly. And this issue, which you can access through the paper there, you can just go online, and once you get online to the JHL, you can access all the issues, and you have a month on it. One of the things contained in this issue is a model hospital policy for baby-friendly in the US. It was not created by baby-friendly, but they have looked at this policy and were very happy with it when we used it in the state of New Jersey. So there is a model policy in there that you can take a look at. Also, there's a lot of papers from all over the world about different things that are going on with the Baby-Friendly Hospital Initiative. Can you not hear me? You can't hear me. It's got the little battery. Yeah. Well, just turn it on. Can you hear me now? Oh, that's better. Okay. I prefer to be like Oprah and like hold the mic, so we'll see if I plug it on, if it works. Okay. I always feel I have to put like, tell me if you can't hear me, okay? So that Journal of Human Lactation has a lot of stuff. There has some stuff about the United States, but it also has stuff from other countries, which is really interesting, like information about the NICU Baby-Friendly Initiative, which is an international initiative that's going on, and a lot of other stuff that you'll find useful. Also, a paper that we did that showed that most American nursing staff in maternity don't actually claim they don't know what the Baby Friendly Hospital Initiative is. So you guys are already way ahead because half of you are here and now you know what it is. So there's lots of changes been going on with Baby Friendly on the international scene. In 2009, the WHO, which is the body that has started and continues at some level to run the Baby Friendly Hospital Initiative internationally, revamped the initiative, which was originally started back in 1991, with some changes and additions, which were just to keep up the initiative with things that had changed in the medical field and internationally during that time. And it's always really important to remember that Baby Friendly is an international initiative. It's not just in the US. So when you get these kind of broad categories and things like hand expression and things, it's speaking to a broad range of nations where things may not be done the same way as they're done here, and it has to always keep that in mind. Some of the changes that they did suggest came nationally in different countries, although the 10 steps themselves did not change. So the revised things it's all on the WHO website if you want to look in any more detail about the initiative and find out more background about it and the recent changes that have been done. But it was basically reorganized into 5 different sections. And also it did talk about lessons learned and what had been done. And I know one of the Oklahoma hospitals has as its motive, if 20,000 hospitals can do this, so can we. And that has been done. 156 countries, probably more than that now. So the calls internationally for expansion for the Baby Friendly Hospital Initiative were to expand it to the community. And quite a few nations have now done this. They have the Baby Friendly Initiative, not the Baby Friendly Hospital Initiative, and they are looking at big communities. So, for example, the community of Milan in northern Italy, they are a Baby Friendly community. So, for example, the pharmacies in that region, that health region, don't sell formula. It's given, under special, it's like a prescription or something like that, and they have to have public spaces for people to breastfeed, workplace laws, the whole community, and any hospital within that community has to be a baby-friendly hospital. And that's actually been implemented in many countries. Italy published about it in that JHL, but it's happening in Croatia, it's happening in New Zealand, many countries. And then there's a lot of stuff going on with babies in special care that I'll talk about for a second. There's an emphasis, as Becky mentioned, on mother-friendly care, that this is not just to make people breastfeed, that this is to improve maternity practices in the hospital for all women, improve education for all nursing staff. And then HIV was not really a big factor at the beginning of the Baby Friendly Hospital Initiative back in 1991. It was only just really emerging. And a lot of things changed in breastfeeding because of HIV. And so the new international WHO guidelines address the whole issue of HIV and what to do in which countries, depending on the kind of... clean water is a bigger threat. Not having clean water is a bigger threat than HIV. So in countries where they don't have clean water, they recommend breastfeeding even if HIV is endemic. And then reaffirming the global criteria, which speaks to some of the code for substitutes of breast milk. So this is the group that's working on the NICU. Those of you who are neonatologists or involved in NICU care might be interested. This was a conference in Sweden a couple of years ago. Of course, they've got everything perfect in Sweden. Everything's just perfect in Sweden and Norway. In fact, 95% of the hospitals in Norway already have certified their NICU separately. They just went ahead and did it. And 100% of hospitals in Sweden are baby-friendly and have been since the beginning. So they kind of got everything right. It's all those long, dark nights. I think they don't have anything else to do. They just breastfeed all the time. So the Nordic group has really gotten the guidelines going for the baby-friendly NICU. And actually, in the JHL from August, they had 3 guiding principles. And this year in August, we're going to publish the 10 steps for the NICU, which is going to be really cool. So, as I say, some places have expanded it to the community. The UK has a very active baby-friendly group, and they have expanded to accrediting regional health centres and educational places. So you can go to a midwifery course, and it can be baby-friendly accredited, the actual course in the hospital or in the medical school. As I say, Norway has 95% of its NICUs already certified. Now, we're a very big country here, so we're focusing on birthing sites because we haven't historically even gotten that right. And it's funny because I'm speaking next week in Spain, actually, about breastfeeding in the United States. And the first thing I'm going to say to them is, That's like asking me about breastfeeding in Europe, because it's very, very different if you're in Sweden compared to if you're in Greece or France, because everyone has very different areas and different standards and different levels of accomplishment. So in the US, we're really focusing on the birthing side, but all this, just to put it in the international perspective, that all this stuff is coming, and you guys are not alone, and it's not just like here we're struggling with one thing and the rest of the world's kind of not bothering. Everyone's working on this. So in terms of the 10 steps, we're going to go through them and we're going to talk about the different things that you need to do for each step. Step 1 is to have a policy which is communicated to all the to the maternity staff, but it has to be a good policy, and now we call it an infant feeding policy. Used to be breastfeeding, now it's focusing on infant feeding because it also addresses women who feed formula. And this is something that you need to have in place, and there was a model one in that JHL, but you guys have quite a few resources here in Oklahoma as well, because there's a model breastfeeding policy for the state of Oklahoma that you can access online. So you do need to tailor these to your hospital. Obviously, you need to be familiar with them, make sure that they fit your hospital, get buy-in from your staff. But there are some models out there that you can work with. There's the one in JHL, and then COBA has its own model hospital policy on breastfeeding, which Becky's behind a lot of it, and it's a very good one, and it's very much up to date with Baby Friendly USA requirements. These slides are accessible, right? So people, you can get this information from the handouts. How do you test step 1? Well, you do get to send it to Baby Friendly USA, your policy, before they come, so that they're not coming down the street and they look at your policy and say, oh, that's useless, we're going home again. You do actually send it to them, and they go through the breastfeeding policy and they check it off, and they look to make sure that you've met their own guidelines, and they send you a tool to be able to assess it yourselves first. So they send it back to you. So you have it right at the beginning. It's one of the first things you do on the baby-friendly process, and then they check it again before you get to the designation visit. Now, what kind of myths? Well, one myth is that this has been known as a breastfeeding policy in the past, not an infant feeding policy, so it's just a breastfeeding policy. That's not really the case anymore. Now it is an infant feeding policy, and so it addresses things like how to teach women to feed formula, also addresses skin to skin and rooming in, which are steps I'll get to in a second, but they're for everybody. They're not just for breastfeeding mothers. And the other myth is that these model policies that are by the ABM and the AAP will do, and they really are not detailed enough. So there are 2 model policies out there, the Academy of Breastfeeding Medicine and the AAP model policy. They are good as a kind of guideline, but when you're sitting down to do the work, you need to take a look at the Oklahoma one or the JHL one, because those are much more detailed and have a lot more of the content that you will need. Step 2, this is perhaps the most complex, but again, you guys are very lucky in Oklahoma to have Becky and her crew who've been working on all this stuff to help you along. So step 2 is that you have to train your staff in the ways that are necessary to implement the policy. And somehow it doesn't quite add up here. Maternity staff, like the nurses and everybody, they need 20 hours of education. And the doctors are supposed to be really, really clever, and they only need 3 hours of education, but they actually have to answer all the same questions. So somehow the doctors have to figure out in 3 hours the real key, because when people come and ask you questions about breastfeeding management and things like that, the doctors are expected to have a very good level of knowledge too. So there are places you can get this to. Becky. There's the BSEP program, which is that big book, which she can tell you more about, I'm sure. But basically, Oklahoma has bought into a big project, the BSEP program, which educates people. And also the AAP on the... Laurie Feldman-Winter is one of the doctors who's been doing a lot of the breastfeeding work. She's one of the chairs of the breastfeeding section at the American Academy of Pediatrics. And she has a whole online program. If you Google AAP breastfeeding, you go into that program. There are PowerPoint presentations in there that make up 3 hours of education that you can use for your doctors. So don't reinvent the wheel is one of the things. There are tools out there for education. In addition to BSEP, if you want to kind of pay more money or there are other programs out there online. There's a lot of stuff. You don't have to sit down and create education from the beginning. And for your doctors, similarly, you don't need to do anything new. It's all available online. You can get through that. So one part of it is the education is the online, the sort of book learning stuff, and then the other part is skills fairs. There is, besides the stuff that people are supposed to kind of study, they have to do 5 hours of hands-on, and some of that can be in the sense of a skills fair. And this is really where we really recommend when we go around the country. Sometimes I feel like I go around the country ahead of Trish, like maybe 2 months to all the hospitals, 2 months ahead of Trish. And the main thing I do is teach doctors how to hand express, because nobody knows. So that's one of the big things I do. So any of those of you, I see some of you in the audience who have actually done that with, don't feel bad, because I've just been doing it last week in Phoenix and Toonley, and we, but these skills fairs are actually a good way to get your interdisciplinary groups together. So you may be holding it mainly for your nursing staff, but you actually need to try and get your doctors to stop by. And I've spoken to places that have come up with pretty creative ways to do this. They've done them either in the NICU or in the delivery area when it's a quiet day, and basically you have different stations so that you have breast pumps set up there, alternative feeding methods, Becky's famous squeaky boobs that you can use for hand expression and also use to show people how to operate breast pumps. And Becky is your great resource. And I have to tell you that if you go anywhere on Route 66, into any Arby's on Route 66, there are people there that know Becky. At least that's my experience. So one time, 100%, right? We walk into an Arby's on Route 66 and the woman comes like, I know you. I don't know if she'd staged it or what. But she gets around all over the state, okay? So she does do all these breastfeeding courses. But within your own hospital, you can certainly do something like this and have your staff do it and have the doctors come through. And, people, there are nurses that have worked on my unit for 20 years that before we went baby-friendly did not know how to put a breast pump together. They just didn't know. And people are embarrassed to ask because they're kind of supposed to know that sort of thing. So if you have a skills fair set up with different stations, you can get people to come and do the skills. So I highly recommend that. Now, the big thing is that Baby Friendly USA, when they go out there, they interview your moms. I can't tell you how many of these hospitals, before I even go out there, I'm like, interview your moms, and people don't do it. The real answer to if you're doing this job right is going to come from your moms, okay? You need to be talking to your moms, and there are tools when you start to get on this baby-friendly thing, when you get your dissemination, I think it is, there's a load of audit tools in there which tell you how to interview moms and what to ask them. They are the proof. The proof is in the pudding, and the moms will tell you. So they interview moms, and they will also interview your postpartum providers. That's not just for this step, that's for all of them. But that's how they test if people have been well trained. They see if the moms know what to do, which is kind of logical, but that's how they do it. And they ask prenatal moms as well. So, one myth is that, that the baby friendly is going to come and, go patrolling through the whole hospital and grab people down, and they're not quite as scary as the Joint Commission guys. They're not quite like that. They do actually interview people that they set up to interview. But, I've been to places and it's not wise to have people wandering around when Baby Friendly comes and say, oh, did you give your mum that formula that she asked for? You have some level of sophistication here, but they're not quite like the Joint Commission. And then this is my universal thing that drives me nuts when I ask clinicians, and it tends to be more the doctors than the nurses, but sometimes it's the nurses. So what do you do if a mom has a problem with engorgement? Oh, I call lactation. That's not the right answer. That's not the right answer, okay? You don't call lactation for the basic stuff. You may call lactation indeed, but you should be able to answer the basic questions as a healthcare provider about positioning and things like engorgement and the real basic stuff. You should be able to demonstrate that. So that is very commonly the wrong answer. Probably every single hospital I've gone to, they've said, and I was at another site. Of course, I have to be a little careful here because Trish is here, so I'm not going to mention any names, and it wasn't anyone here. But I was talking to their senior leadership at the beginning of the session, as Baby Friendly does. And this was a couple of months before Baby Friendly came, and I said, well, if Letitia, the lactation consultant, weren't here, would this fall apart? And they said, oh, yes. And I'm like, well, that's not the right answer either. That's not the right answer either, because you really, as we all keep saying, it's a team thing, and you should not be depending on one person, okay? So if you find that you're tending that way as you set out on this journey, it needs to be spread. And I can tell you, as you get closer towards the end, there's just no way. You can get through certain parts of it at the beginning, But as the rubber hits the road, you need all those groups of providers on board. You need your doctors, you need your obstetricians, you need your, post, pre, everybody needs to be involved, because you can't just do it with one group of people. And the people that don't get on board are going to get left further and further behind, and then you're going to have more and more work to bring them up to speed. So you really need to get a group on board right from the beginning. The pregnant moms have to be informed about breastfeeding in your prenatal clinics. Make sure that they get their prenatal education by about 30 weeks. You're going to have to think this through now, because often I think I have the myth of this one is that people think it's being done. Well, it's probably not being done. Or maybe what's being done is people are being handed a piece of paper in the prenatal clinic about breastfeeding, but no one's really reading it. So you need to figure out, and I know Jenna from Claremore has really worked hard on this in their prenatal section, to figure out like where the teaching is going to happen, which session, and even to the point of practicality of putting like a sticker on the chart for the first prenatal, remember to do this breastfeeding education, remember to do that. Or I've recommended putting like a doll or a breast into the room so that the provider or the nurse has a tool there that visually reminds them that they need to do prenatal education at this point. And then it needs to be chartered, which often you don't chart. And when Baby Friendly come, they're going to check to make sure this is happening if it's documented. And of course, if it isn't documented in the hospital, we all know that it didn't happen. And the same goes for breastfeeding. So again, it'll be interviews that it's tested on. And one thing that those of you who have smaller sites need to remember is that for interviewing patients, they need a certain number of patients. And for the small sites that only do a few deliveries, some of the Indian hospitals, they're going to go back and look at your charts from previously, because you didn't have enough patients in the hospital, or you didn't have enough women who had cesareans, for example. So you need to have the charts, not just for the people who happen to be there that day, but you need to have access to people. And I can tell you it takes a lot of organisation to plan to phone people up and do that kind of thing. It's very difficult. So one of the myths is that somebody out there in prenatal care is taking care of this, and I tell you, they're probably not. And it's interesting that, sometimes people do also ask me about, like, if the clinic's not part of my hospital, what am I supposed to do? In those cases, you're not responsible for them, but their moms are still coming to you. So a couple of things I would tell you about prenatal care that is very unlikely to being done before someone goes in there and does this on purpose is skin to skin and rooming in. These are like the buzzwords of baby friendly. That's what happens when these women come to the hospital and they need to know it's going to happen to them. And in fact, it helps you, because if you tell them prenatally and they come in asking for it, it pushes your providers to provide it for them. So if there was just a couple of things I would say to you, Kate, make sure that you're looking for in prenatal education that probably were not there before, it would be skin to skin and rooming in, which I'm going to talk about separately. And I would get that information out to your prenatal clinics, because that's probably the thing that they have no idea about. Then the moms come in and they have no idea about it either. So you hope they're teaching them positioning and latch, and maybe they're not doing that either. But it's pretty sure that unless they've been talked to by you about what the hospital is now practicing, they're not doing skin to skin and rooming in as part of prenatal education. And of course, you don't have to educate every single provider on the planet, but anyone who's in the hospital doing a delivery on the day a mom, the day that your assessors are here, those people are going to be interviewed. So you really do need anyone that has privileges, not just for the assessment, but for your practice. You need to have them educated as well. So this is my favorite step. Help mothers initiate breastfeeding within 1 hour of birth. This is now interpreted as put moms and babies skin to skin for the first hour of life. And if you do that, the breastfeeding will happen. It's not just for breastfeeding moms, though. Every mom and baby should be going skin to skin at birth, whether they're breastfeeding or formula feeding. This is something that is considered now to be optimal care. This particular picture was sent to me by one of the Indian hospitals I'm working with, and this is a cesarean mom. The requirement is there for cesarean moms that when they can respond to their babies, they also have them skin to skin. So skin to skin is a really pretty cool step. And this again is taken from a Gallup Medical Center, which is an Indian hospital. And I just love this picture. This was actually one of the very first skin-to-skin deliveries that this hospital did, in the cesarean. And if you look, I think, I've heard Trish use these words that skin-to-skin is a game changer. Skin-to-skin makes people change. It moves people. It makes everyone happy. And if you look at the people, the anesthesiologist and the OB people, they're actually smiling behind those masks. You can see it from their eyes. And the mom, of course, is smiling. And all babies, regardless of feeding method, need to go skin to skin in the OR as well. So now, all babies is when they're medically okay, all right? You don't need to do this if people are having general anesthesia. And I've had people say to me, I talked to some moms that, oh yeah, they put me skin to skin, but I don't remember anything about it because I was out. And I'm like, oh my goodness, we don't want that to happen. So, it doesn't have to be the case when people are really not well. But if everything's going according to plan, and Becky's going to be talking a little bit about PDSAs later on, and when we talk about trying to do this and initiating it, you want to pick a planned cesarean where everyone's on board and it's all under control and it's something that you can do with some level of control. So clinicians are going to have to learn how to do it. Obviously, if it's a non-cesarean, it's a much simpler process. Basically, you just do that. But you may need to change your routines, delay procedures. You must monitor the mom and baby in skin to skin, of course, when they are in skin to skin. It needs to be documented when the baby went to skin, and they will ask the mom, did the baby go skin to skin? How long was the baby there for? So your documentation is going to have to catch up with your practice. Traditionally, your practice has changed, and then suddenly you have to deal with documentation as well. Couple of